Right. I'm so sorry. Somebody else's presentation was in that folder today. So, right. So, we'll be talking about challenging complications after glaucoma drainage surgery and a few tips of management. They're all uh, individual. Once you start doing, everybody has their own way of dealing with these complications. These are just our perspectives. So, the complications could be an exposure of the tube or the plate. So this is very distressing to see when it comes, but it does happen. Once you're going to put in your tubes, be ready to face these horrible exposures. Then you can have tube complications. You can have a corneal touch, or you could have a tube which for some reason is too long. You can have infections, you can have inflammation, you can be faced with endophthalmitis as for any other surgery, and there could be hypotony as well. So the principles of management for exposed tubes and exposed plates, they need to be repaired immediately. There is no wishful thinking that this problem will go away on its own. Typically, as a dissection of eroded conjunctiva, a placement of a dual layer of coverage, either a sutured patch to cover the exposed tube and a conjunctival overlay. But if you think the conjunctiva is not enough, you might have to have autografts from either the same eye inferiorly or even the other eye. So this is a patient who's come with the tube exposure. So she's received a scleral patch graft over the tube as well as a conjunctival overlay, and this is about a month or two later, and she's all right. So my slides aren't moving. Yeah, okay. So this is another one. Sometimes you have an exposure which extends onto the plate and the sutures. Again, you need to give an overlay and cover the area before any infection or anything else develops. Sometimes you might have to use a free conjunctival graft or even double layer amniotic membranes under the conjunctiva to give an additional layer. And at times, we've also used buccal mucosal implants because they're one eyed, the other eye is thicycle, there's no conjunctiva at all. The idea is so that's what a buccal mucus membrane looks like. It looks a little thicker, but at least it covers the plate and it's better. So, coming to the problems of the tube, if it's a corneal touch, then you need to reposition it, or there's something that we've also looked at, which is a tube sling. So, sometimes you won't want to go in and you would like to do something less invasive. If it's too long, then you need to cut it. If it's too short, you'll just have to take it out and try and reposition. And sometimes it disappears, and then you need to seek and recover and find it and get it back in place. So we look at some of these problems. This is a typical tube corneal touch. Now, if you already see the cornea, do you have a pointer by any chance? So if you see the cornea is already getting opaque at a point of the tube, and if you leave this cornea is going to decompensate someday or the other. So again, wishful thinking won't work. If you see this little thing here, you know this tube is going to cause trouble. So the best thing to do is take it out, and it was repositioned a little deeper, and then it does all right. And you can see the cornea there is much better after repositioning. Sometimes you need to reposition in a peephole. What that means is there is a tube corneal touch there. You can see this on the ASOCT. It is even indenting the cornea. So there's no point thinking that this cornea, this problem is going to go away. So, since he had an absolute shallow AC and a shallow anterior chamber, what we decided to do is form a small peephole and reimplant it into the sulcus so that you could see the tube. So, you see post op, this is the tube here, it's behind, but for you to be able to see it post operatively, you make a small iridectomy and you reposition the tube in the sulcus so that you could see it. And he's pseudophakic, so this can be done. Now there's another patient. Look at this. It had a so this is an iris which is tucking into the tube. Sometimes it might happen the bevel is too shallow. So here it is. This iris is tucking in, and the pressures have gone up, and there's something that you need to do. But he's already he's got good vision in the other eye, but neovascular glaucoma in one eye, ADI implanted. So you think, let's not go in all over again, because neovascular glaucoma with diabetics can be troublesome to fiddle in too much. So this is something which we tried, and sometimes it does work quite well. So this is something called a tube sling. It's a simple procedure to do. So, what the only thing, the principle is that you just put in a sort of harness in front of the tube and pull it hard so that the tube just goes in. So, it's a simple thing. You just take this, you go between the cornea and the tube and take this suture and just do a tight suture of a 9 nylon, because you need something thicker, but a 10 can be used if you want, but this is 9. And then you tie it in, and you'll already be seeing the tube going a little back, and it can be behind the cornea. Then it's not touching it anymore. So there you are. So this is one day, and he stayed like that, but you're scared because sometimes this might, it's after all a conduit to the anterior chamber, isn't it? So at 6 months, we thought, let's remove it and see. And thankfully, it's sort of fibroses and it stays that way away. And it works quite well sometimes if you can. So it's just short of a repositioning. If it doesn't work, we can go in and reposition it again. This was an interesting case, so I thought I'd bring it in. I dug it out actually. This 28-year-old man with trauma had a complicated cataract and retinal detachment. He had post PPV glaucoma and he had a scarred conjunctiva as well. The AGV was uneventful. So, this is how he was for a while. And in 3 years, the IOP started rising. So, these patients are going to be with you for life. And then when it started rising, we realized there's a bit of congestion there and there's no tube visible in the AC. So we tried a gonioscopy, there's no tube visible in the angle. So now you know that the tube has disappeared somewhere and it's also causing inflammation there. So why should somebody who was completely quiet and all right come back with a congested conjunctiva and absence of tube? So obviously something has happened. So we thought we'll just have to explore it. And this was interesting. So it's a bit of a longish video, but so we started our exploration to seek and find. And you see, there's no tube there. So it's gone down. So we're still finding. This was quite long. So I have cut it into many segments to try, and so still searching. And then we went under the plate and it's still not there. So it was quite amazing that where has the tube disappeared? And we're sure there was a tube there. So we took the plate off and came up to the plate of the graft, and we're still searching. And we know it's an AGV. And believe it or not, this entire plate had rotated, and the tube had rotated along with it, and it was curled up in the fornix along with the plate. So that was quite a surprise that, the tube can do anything, and we have no idea how it's retracted, it's gone up, it's curled itself against its plate. And my senior resident there at that time said it's like a baby going back to his mother. So we called it a fetal position of the. So there you see the tube. So the tube had gone up, and there it is. So you can see where the tube was. So it's a pretty longish tube there. There's no problem with that to reimplant it. But for some strange reason, it had just gone up, curled up, sat with the plate, and it was up there in the phonics. So that was interesting. This is the only case that has happened, that the AGV has just rotated on itself and also taken the plate along with it. So, of course, it was just easy to reposition it. I just wanted to show this bit. So, sometimes you have valuable lessons that you learn. So, this 8-year-old girl with microcerophakia who'd already undergone a PPL had undergone an AGV, and now the right eye IOP started rising. So, we decided to put in an inferonasal ADI. Now, the pressure was 30, which is not unusual for an ADI because we ligate the tube. But what was worrying was this. So you have these vitreous strands which are going into the tube. And again, wishful thinking is not going to help. If we are not going to clear this up, this tube is not going to drain too much. So the lesson learned is even in a vitrectomized eye, so we assume she was PPL and PPV, or rather anterior vitrectomy, so the sulcus would be clear. But even with a vitrectomized eye, remember to do a skirt vitrectomy under the iris, because the vitreous might still be there, and the minute you put in your fluidics and it hydrates, it will come up again. So be careful of that. So the easy thing to do, and you can see how early it is. We took the girl up again, even though it was a repeat GA, went in with a cutter. So since it was inferonasal, here it is, and look at all that vitreous around the tube. So we just ate all that up and did a good skirt vitrectomy to clear out the vitreous under the iris. And once the tube was cleared of the vitreous, now you can see how clear it is. Then the IOP stabilized and you could re-establish drainage. So the moral of all glaucoma, if anything, is look for a cause. It's not enough to just give Diamox to every glaucoma that comes to you. Look for the cause, try to treat what is happening, and usually that's what works. Of course, the most dreaded complication is endophthalmitis. It's something which we wish would never happen, but it's going to happen someday or the other. So you need to act promptly. There's no two ways about it. Invariably, we have to remove the glaucoma drainage device. I don't think we've tried at times. Thoda sa hypopion hai. Let's see. Maybe we can salvage. We can't. The only thing that works is removing that foreign body there because it's not going to let the eye heal. Intravitreal antibiotics culture the tap. Usually, the infection is limited anteriorly, so there is a case for doing an AC wash rather than intravitreal, but we need to remove as much of the infective load as possible. So, this is a turbulent journey. This 22-year-old girl with intractable JOAG and a failed TRAB had an uneventful ADI. 2 weeks later, she came to us with this, with hypopion exudates around the tube. We searched and searched in 2 weeks, but we found no dehiscence, no erosion, nothing to explain it. So it was quite disappointing for all of us. But immediate surgery, we explanted the adi there. You see, it's a fresh conjunctiva, fresh thing 2 weeks ago, but we still took it out. And then daily monitored, the vitreous trap showed staph aureus, sensitive to vanco and cephalexin. There was no appreciable improvement in 3 days, and we were getting really worried because this hypopion just stayed where it was in spite of giving IV and an intravitreal. And then we realized the muck is anteriorly, and we haven't addressed that. So then what we did was took her up again and did an AC wash. We just removed all this stuff which was there. And then once the infective load was down, she was much better. And you can see she settled down well. And thankfully, we salvaged her vision as well. So the take home points are tube entry should be as far posterior to the limbus as possible. That prevents erosions better. Cover the tube with a patch graft or a scleral tunnel every time. There is no case for not doing a patch. The cover should be parallel, the tube should be parallel to the iris. Ensure a long bevel and secure the plate nicely to prevent movement. I'm not sure whether that AGV with rotated was because the securing wasn't tight enough. Tell the parents to take care children don't press on the globe or rub their eyes too much, and if they do, they need to come back and address the problem.